Hi, everybody, and welcome to ASCO Highlights. Thanks for joining us on this beautiful Sunday afternoon. It's actually quite beautiful in Philadelphia. I hope that everybody can enjoy some outside time after these sessions are over today. But I'm excited to be here. I'm a thoracic and head and neck oncologist from Fox Chase Cancer Center, as you saw in my talk. And I'm here with Ryan Gentzler from University of Virginia. And we're excited to answer any questions that you have today based on the abstracts that were presented on both metastatic non-small cell lung cancer, as well as the potpourri of abstracts of more local or local regional disease.
Thanks, Jessica, for that introduction. So we're happy to take any questions. If you place those in the chat, we'll be able to see those and take them as we go. But maybe as we wait on some questions to come in, I thought I'd ask you, Dr. Bauman, what your thoughts are on the IMpower10 trial. And, obviously this is not FDA approved at the moment, but if it were to be, based on the primary outcomes and the patient selection for this trial, do you think that this is something that you would apply in your practice? Is this something that's ready for prime time? Do we need to see overall survival number before you would update this? I'd be interested to get your thoughts, and I'm sure the audience would be curious about that as well.
Well, I think all of the above. I mean, I think that it is interesting that this comes to us with disease-free survival data, which is the same as the ADAURA study came. And I think a lot of us really would have loved to have overall survival data with ADAURA as well, but interestingly, osimertinib was approved based on disease-free survival, and I think we're seeing that more and more. Certainly, the data looks robust, and it looks particularly robust in the PD-L1 positive patients, which I'm not surprised by. And I do think that absolutely, based on what we have so far, I would think strongly about this, at least in my PD-L1 positive patients. I want to see more information about the different cohorts, because certainly based on all of the data that we see in non-small cell, really understanding the PD-L1 negative versus PD-L1 1 to 49 and then PD-L1 50 or greater will be helpful. And certainly I will want more granularity on those patients who have molecular alterations, specifically EGFR and ALK, because they did have, I'm just going back to the very specific numbers, I want to say a little less than 10% of patients had EGFR mutations. So it was, so 11% of patients had EGFR mutations and 3% had ALK. And traditionally, we don't think of EGFR and ALK as those who respond well to single agent immunotherapy. And so in general, I will likely shy away from that, but I want more specifics for those populations. What are your thoughts about it?
Yeah, so I have similar thoughts on this. I certainly agree with your comments on the EGFR and ALK, especially in the setting where we have the ADAURA data, with very strong disease-free survival benefit with adjuvant osimertinib. I'd be much more inclined to give osimertinib to those patients rather than immunotherapy. And I think it's interesting that they were included in this trial, and would be nice to see, how those, whether there's enough numbers to really tease much out. We may never see that, but I would shy away from that. I think, the PD-L1 positive population certainly seems to derive the most of the benefit here. I think I would be pretty careful about someone with a PD-L1 negative. Certainly if they were motivated and had high risk disease, perhaps I'd be swayed to consider it. But I think I'd probably try to adhere mostly to the PD-L1 positives. There have been some comments and discussions since ASCO about what about the 1 to 49 group versus the 50% positive group. And I think if you do some math in your head, you could make up a story that maybe the 1 to 49 group isn't doing as well as the PD-L1 high group. But I think we've seen that in multiple trials. We've seen that in the Pacific trial, that there seems to be increased benefit for the higher PD-L1. But I think these are the data. This was the trial design, and it was specifically looking at first the PD-L1 positives and then the group as a whole. So I think to tease it apart even more, it gets a little tricky as well. So I think I'd stick with the PD-L1 positives. But yeah, I would recommend this based on a DFS. And I think it's, I don't know your thoughts on this, treating other cancers, but I feel like we see a lot of controversy and discussion around DFS versus OS in the lung cancer space, but other cancers, breast cancer, GI cancers, are willing to adopt based on a DFS improvement alone. I think this is statistically significant. It was the primary endpoint. We'll see how the FDA feels about it, but I think if they approve this, it'd be something I would routinely adopt in my practice.
Yeah, absolutely. In particular, because we know obviously immunotherapy has completely taken over the recurrent metastatic space, right? And so it's not a surprise that we would see potential benefit early on. So I agree. I also think the other population that we'll have questions about is the stage 1B, because when they did include the full intention to treat analysis, that's when the relationships became less pronounced.
Right.
And so I do wonder if the stage 1Bs will ultimately not be ones who we will consider it for.
Yeah, I think it was a tricky statistical design just with the hierarchical analysis, but that's right. I think when they looked at the third hierarchical endpoint, including the 1Bs, it did not meet significance. Whether that evolves with time and longer follow-up, I guess we'll see.
Right. The other thing that I think is increasingly intriguing is is other biomarkers that will allow us to figure out who are the people who are responders. And so that we're not exposing the entire population to something that has real toxicities. And I do think there's some interesting some work with ctDNA, in particular in the setting of adjuvant durvalumab, where you can see from a group in California, where you can see the patients who still have positive ctDNA, and then they go on to durva, and you see it respond, versus those who've already cleared by the end of chemoradiation. Again, this is stage 3. Right. But I think that will be something that will be fascinating to see moving forward in these large trials, so that we can really get a sense of, are there people who clear with surgery alone, right? Or surgery and then adjuvant chemo, and then perhaps those patients do not, in fact, need further immunotherapy. So I think more creative biomarkers in this space will also be really helpful.
Yeah, I think that's, especially in the surgical, compared to Pacific, where most of those patients will, recur, or at least 80% historically. But if you have a stage 1B or stage 2A, maybe those patients have a 50, 60% chance of cure with surgery alone. So it makes sense to tie in other biomarkers to figure out who those patients are versus those that actually need it.
Right. Absolutely. So so there are a few questions coming in. So thanks for those who are listening and who are sending questions our way. I think one of the questions that I had also had for Dr. Gentzler myself is the new decision of what in the world do we use in the frontline setting for new non-small cell lung cancer with metastatic disease, right? When do you use Nivo-Ipi? When do you use chemo Pembro? When do you use Nivo-Ipi chemo, like Checkmate 9LA? What are your thoughts about this? How do you wrap all this in your head?
Yeah, it's rapidly become a very crowded space with a lot of options, a lot of FDA approved options. I think that we obviously don't have head-to-head comparisons of immunotherapy containing regimens. Everything so far has been compared to platinum doublet chemotherapy. So it's hard to identify which of these regimens are superior to one another. We are starting to see longer term, survival numbers from all of these trials. And as I talked about in the talk, it doesn't seem to be a whole lot of difference, between Keynote 189 or 407, which were split up by squamous and non-squamous histology, and the Ipi-Nivo regimens, whether that's Ipi-Nivo alone or 2 cycles of chemotherapy plus Ipi-Nivo, as we saw in the Checkmate 9LA trial. And I really don't see much of a differentiating factor in terms of survival, which I think is the key marker here, that make me feel compelled to use that regimen as an upfront regimen. I think some of this depends on the biomarkers. I think PD-L1 is a very critical first step. And well, first of all, genomic testing. We always want to make sure we're not treating someone with EGFR or ALK up front with one of these regimens, or probably most of the other biomarkers with FDA approvals. Next is PD-L1, and I think if you have someone PD-L1 50% or higher, we have even more options, between single agent immunotherapy versus chemotherapy plus immunotherapy. But I think for the negatives in the 1 to 49 group, my standard still is platinum doublet chemotherapy plus pembrolizumab. I think it's a well-tolerated regimen. I think the immunotherapy related adverse events are manageable with the single agent immunotherapy. I do worry a little bit about adding ipilimumab up front with some of those, as we saw in the talk, those first 1 to 2 to 3 cycles are higher immune related adverse events. And I think that we see that earlier on when you add the ipilimumab. And if we're not seeing differences at 2 years or 3 years survival, I think it's hard to adopt that as a standard regimen. We were talking a little bit before the session started about, is there anyone where you'd think about the ipi-nivo regimen? And I think that there are some in theory where it would make sense. Patients who just really don't want chemotherapy, patients who aren't a candidate for chemotherapy, maybe that's because of CKD or other things that make it difficult to give pemetrexed, or you're just worried about the platinum agents with CKD. But I also feel like a lot of those patients also overlap with worse performance status. Then if you have poor performance status, do you feel comfortable giving the ipi-nivo regimen? I think that that's always just a tricky judgment call. When the patients sit in front of you, how are they going to tolerate any regimen that you prescribe? So for me, I stick with the chemotherapy doublets plus pembro in most cases, and think about sort of select scenarios where it makes sense to consider one of the other options that we have.
And what about in your PD-L1 high? You're greater than 50%.
Yeah, obviously we don't have head-to-head data there. We are enrolling to clinical trials that are randomizing to pembro versus chemo plus pembro in that scenario, which I think are very important. The off trial, options for those patients, both of those exist as well. We do see higher response rates, if you look cross trial comparisons with the chemo plus pembro. So in my practice, I take a couple of factors into consideration. Are they a good chemo candidate? Can they tolerate it, fairly well, or are they more borderline? And then what's their disease burden and symptomatic burden? And I think that we know from multiple lung cancer trials over the years that there are many patients who do not make it to second line therapy. And so saving the chemo for second line may be fine for a good proportion of patients, but those with heavy burden or symptomatic disease, as long as they're a good chemo candidate, I have probably about a third of my patients would recommend the chemo plus pembro up front. And for the others who are either not great chemo candidates or less symptomatic, try to get away with the single agent immunotherapy. And if it works, and it tends to be very durable. And then you at least push the chemotherapy down the line, hopefully a couple of years.
Right.
So I think it's case by case. I don't have a one size fits all, but that's how I approach that scenario.
Yeah, same with me. And because I think that even though, yes, there is somewhat of an improved response, and it will be great to have trials that really tell us this answer, the toxicity is very different, right? Of single agent immunotherapy, either pembrolizumab or cemiplimab is now approved in that area as well. But compared to chemo immuno, right? And especially even in the maintenance phase with pembro and pemetrexed, the toxicities after, yes, it's great. They can respond really well and really long, but it's still, the low grade toxicities over time can really build up.
Sure. And that has an impact on quality of life. And if it's going to be someone who would have a 2 or 3 year PFS on single agent pembro, is it worth it having that effect from the chemotherapy?
Right. Agreed.
Yeah.
Agreed. So an interesting question. The person has a 48-year-old woman who has high PD-L1, so greater than 50%, and a ROS1 fusion, who received 3 cycles of cis-pem as neoadjuvant and then went on to surgery. They then underwent pneumonectomy and lymph node dissection with a minimal response, still is T2N2 with 15 positive lymph nodes. How would you treat this person now in the adjuvant setting, and restaging shows NED?
So that is a tough case.
Yes.
Certainly would have hoped for a better response to the neoadjuvant chemotherapy.
Mhm.
I think that this patient has gotten the right treatment to date. I would emphasize that the standard of care in a surgically resectable patient would be either neoadjuvant or adjuvant chemotherapy. That's the only thing that's been shown to be curative in the early stage, space. N2 with 15 positive lymph nodes makes me nervous that this patient is going to have a high risk of recurrence. And certainly the fact that they did not seem to have much, or if any, response to chemotherapy means this is a pretty aggressive disease. The PD-L1, I just make a comment on that. I don't find that as relevant to treatment decisions in this case. This is a young patient with a ROS1 rearrangement. I don't know smoking status, but I assume light or never smoking in this situation. And I think that while ROS1, we don't have robust data, retrospective or otherwise, about the effectiveness of immunotherapy. I just think it's going to be lower than average lung cancer patient with a high PD-L1. So I would not apply the Empower 10 trial to this, and would probably not give adjuvant immunotherapy. I think probably the question that this person is getting at is, should I give a ROS1 inhibitor as adjuvant therapy? And that's a tough one. I think that we have oral tyrosine kinase inhibitors that are very effective for ROS1, and entrectinib, certainly crizotinib is effective as well.
Right.
And probably on par with what we expect out of osimertinib with EGFR lung cancer, if not better in some cases. So can you extrapolate from ADAURA and say that this patient is likely to benefit from entrectinib or another ALK or a ROS1 TKI? I think the answer is yes. The question is, are there toxicity differences? I think that without randomized prospective data, how well is a drug like crizotinib tolerated for multiple years' time in a potentially curable situation? But I think that this patient has a pretty high risk, and I think if they're motivated, it would be reasonable to discuss it and offer that, with the caveats that we have no data. The other big factor is payer. Is this something that would be approved that you could use? I don't have any personal experience trying this, but it would have to be certainly off-label or compassionate use, or some alternative way of getting the drug.
Right. And we still don't have good data that using it now versus using it when this person becomes metastatic makes a real difference.
Certainly not in terms of overall survival, so I think that you could easily make a case to say, watch and wait, and we have good drugs if and when this recurs. I think one thing that I probably would think about in this patient would be MRI surveillance. At least once post-operatively, make sure they haven't developed brain metastases in the interim since, having surgery and finishing chemotherapy.
And certainly you'd want to keep a much closer eye. I think the other real question for this person is the role of post-operative radiation therapy, especially if they didn't have neoadjuvant chemo radiation. We would have treated this person with chemo radiation prior to surgery. And I think that there's some new controversial data that was presented last year at, I want to say ESMO.
Yeah, there's ESMO. Yeah.
But there with what is the name of this?
Lung ART.
Lung ART. Yes, I was going to say ART scan, and that didn't sound right. So lung ART trial, which looked to sort of discount the role of radiation, but it certainly was a study where they were not necessarily using IMRT there. So the toxicity from radiation can be very significant. And so because it was not using sort of the newest, best technology in terms of radiation, there's some real question about the validity of the study in terms of, and how we can really use it to apply to our own patients. So we definitely still consider, for incidentally found N2, we definitely still consider the role of radiation in that setting. And so that, to me, that's the other real question for this person, is whether she needs adjuvant radiation.
Yeah, I think that's a great point. I think we have shied away from port in many of our patients based on this lung art, but that trial included all N2 disease. This patient, I don't know if all 15 of these lymph nodes are mediastinal nodes, but perhaps this is a highest of high risk of N2 that it may make sense to think about the adjuvant radiation in this setting.
And then I guess the question of whether they also asked any more chemo, since she only got 3 cycles preoperatively. I think that it does raise the question of whether you want to consider more chemotherapy adjuvantly. I think that I wouldn't use pemetrexed. I would consider a taxane-based adjuvant regimen, and certainly is something to consider, plus minus radiation.
Yeah, I think that we have data from decades ago that 3 versus 6 cycles of chemotherapy in the metastatic setting did not change overall survival. Do you get any incremental benefit going from 3 to 4 cycles or 3 to 6? Probably not a huge amount, but I think the fact that this patient had no response to pemetrexed, I would, if you're going to do it, I would change up the platinum doublet, as Dr. Bauman mentioned.
Ooh, this is interesting. Currently recommended to undergo port with carbotaxel followed by durva.
So I think, there's clearly the standard here would be to do concurrent chemoradiation if this patient had positive margins. I don't know that we know if this patient had positive margins or not. That was not mentioned, so I suspect not. I don't know that I would do concurrent for this.
I'd be very concerned just of the toxicity of concurrent chemoradiation. It's really, in general, is not what we recommend. I think port alone makes sense. And I think the question of durva is a challenging question because as you know, Pacific did not include patients who had undergone surgical resection. And so even though, yes, she has stage 3 disease, the recommendation is not to go on to immunotherapy after surgical resection of stage 3 disease, even with radiation. And certainly we've had issues of payers in this setting because it's not approved and it's not on the guidelines. And then I think it goes back to the original question for this is a patient who's unlikely to, we know that ROS1s, even with a PDL high, do not respond well to immunotherapy alone. And so I would advise against durvalumab, or I wouldn't say that in my practice, I would not use durvalumab in this setting.
Yeah, I wouldn't say that it's wrong. It certainly, fits within the guideline or the FDA approval and the label. I think I'll just emphasize this point a little bit more. There was a trial a couple of years ago. I think this was 2019 in the Annals of Oncology. It was eventually published, but there's this trial called the ImmunoTarget trial. Obviously, this is all metastatic setting, but they looked at immunotherapy responses and PFS in patients with oncogenic drivers. And they looked at all of the mutations, not just EGFR and ALK. And pretty much across the board, these patients did not see the benefits from immunotherapy that we see in the non-mutated. ROS1 was a small subset of that. It's hard to draw conclusions about any of the individual mutations, but as a whole, the story held true with what we've seen with EGFR and ALK. And so I think it's, again, whether it's adjuvant atezo in this case, or if there was a positive margin and you treated with chemoradiation and talking about durvalumab, I would hesitate to do that.
Okay.
So I think we're getting close on time. So appreciate everyone's thoughtful questions and an interesting case that we were able to discuss. I think there's a lot of fascinating data from ASCO this year in lung cancer across the board, and we just sort of skimmed the surface of two, potentially significant and practice-changing trials. We really appreciate your attention and hope you have a great rest of your weekend.
Yes, absolutely. Thank you so much, Ryan. It's been enjoyable.
You as well.